welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website. Today, we have Maddisen Wycoff, who is a PGY2 emergency medicine resident at OhioHealth Grant Medical Center. She will be presenting a journal club on a comparison of ketamine to midazolam for the management of acute behavioral disturbance in the out-of-hospital setting.
Methodology and presentation of acute agitation, assess previous literature and guideline recommendations surrounding acute agitation, and we're going to analyze a recent trial assessing the difference between midazolam versus ketamine for the treatment of acute agitation in the out-of-hospital setting. Acute agitation is defined as a broad group of behaviors characterized by excessive motor or verbal activity manifesting as irritability, uncooperativeness, psychomotor restlessness, aggression, and/or violent behavior. There could be a lot of causes of acute agitation. Just to name a few, so we have metabolic and endocrine causes, which could be something like hypoglycemia, thyroid emergencies, metabolic derangement. We could have infectious sources, especially with our CNS infections like meningitis. We could have neurologic, which would be patients who present in a post-ictal state, have a history of epilepsy, or have an acute or chronic TBI. It could be toxicological. So this could be ingestion, intentional or unintentional illicit substance overdose, alcohol withdrawal, or intoxication. We could also have psychiatric, which would be psychosis, dementia, PTSD, known or unknown underlying psych history. And then we have some other categories like trauma, burns, cardiovascular, and just the emergency room environment in general could be a cause of a patient's agitation. The ideal treatment of agitation addresses the underlying cause rather than just completely sedating the patient. So based on guideline recommendations, we have a few different options. Antipsychotics, benzodiazepines, or ketamine are all reasonable in this patient population. I will say antipsychotics will treat the underlying cause and provide sedating effects. However, benzos, they really only are able to treat the underlying cause in certain patient populations, like those who stimulant intoxication or have alcohol withdrawal. And ketamine is purely just used as a sedative, so it will not do anything for the underlying cause of the agitation. There are recommendations by the ACCP clinical policy. Their recommendations are that midazolam plus droperidol is the preferred regimen due to the safety profile, and they result in more rapid sedation, or midazolam plus an atypical antipsychotic. If a single agent is necessary, droperidol or an atypical antipsychotic is preferred over midazolam alone. There is currently no recommendation from ACCP over which regimen is preferred in the out-of-hospital setting. They do comment, though, that ketamine IV or IM can be considered when a patient, bystander, or medical staff safety is a concern. So getting into a little bit about the drugs we'll be talking about today. Ketamine, the mechanism of action, is a non-competitive NMDA receptor antagonist that blocks glutamate and stimulates mu-opioid receptors. The onset of action for IV will be within 30 seconds. IM, the anesthetic effect will be about 3 to 4 minutes. Analgesia will be about 10 to 15 minutes. Dosing for agitation can vary based on your site's protocol or guidelines. IV is typically 0.5 to 1 mg per kg or 1 to 2 mg per kg. IM is 2 mg per kg or 4 to 6 milligrams per kilogram with a max of 400 milligrams. Duration IV is about 5 to 10 minutes. IM for anesthetic effect is going to be 12 to 15. Analgesia will be 15 to 30 minutes. Adverse reactions we want to look out for in ketamine administration is emergent reaction, hypertension, tachycardia, airway compromise, or increased intraocular pressure, just to name a few. Midazolam is going to work by enhancing the affinity of GABA to its GABA-A receptors. The onset of action IV is 1 to 5 minutes. IM is about 15 minutes. Dosing for agitation will be IV or IM, 2.5 to 5 milligrams repeated every 3 to 5 minutes for IV or every 5 to 10 for IM. Duration can vary, so IV is going to be about 7 to 75 minutes depending on dose, and then IM is going to be 20 to 120 minutes. Adverse reactions will be apnea, hypotension, and bradycardia. So the main concern with using ketamine for treatment of acute agitation is going to be oversedation, leading to the need for intubation. So I pulled a few recent studies that looked at ketamine versus midazolam or ketamine alone in the treatment of acute agitation in the emergency department. So we're going to go through those on the next few slides. The first study is pre-hospital sedation with ketamine versus midazolam, repeat sedation, intubation, and hospital outcomes. So this is a study done in 2020. It was a retrospective chart review of 163 patients who were chemically sedated for acute agitation by paramedics in a large EMS agency and then transferred to an urban level 1 trauma center. There were 97 patients who received IM ketamine. Most of these received a 300 milligram dose. However, there were 4 patients who received a 150 milligram dose due to their body weight. There were 66 patients who received either IM, intravenous, or intranasal midazolam. Most patients in this group received a 5 milligram dose. However, there were 3 patients that received a 2.5 milligram dose. The primary outcome looked at repeat sedation. There was a statistically significant difference in repeat sedation at 90 minutes, with 60% of patients in the ketamine group compared to 39% of patients in the midazolam group requiring repeat sedation at 90 minutes. I think this definitely makes sense based on the pharmacokinetics of each of the agents that we talked about on the earlier slides. Intubation and hospital length of stay in hours were not statistically significant in this study. Like I said, intubation is the big concern with administering ketamine, and this study showed that there was no difference. Actually, a greater percentage of patients in the midazolam group actually required intubation. So the author's conclusion is that ketamine remains a safe and effective option for the treatment of acutely agitated patients, despite the lack of statistically significant endpoints in this study. I don't necessarily think we can definitively say from this study that ketamine is a safe and effective option. I definitely would like to see a larger study with different outcomes looked at. The next study is going to be pre-hospital use of ketamine versus midazolam for sedation in acute severe agitation. This was done in 2024, a retrospective cohort study. There were 134 patients who were severely agitated with an initial RASS score of at least 3, who were sedated and transferred to a tertiary care facility and level 1 trauma center. There were 68 patients in the intramuscular midazolam group who received a mean dose of 5.6 milligrams, and 66 patients in the intramuscular ketamine group who received a mean dose of 288 milligrams. The primary outcome they looked at in this study was intubation. So 6.1% of patients in the ketamine group compared to 2.9% of patients in the midazolam group required intubation for a p-value of 0.38. They also looked at RASS post-drug administration. So patients who had a RASS of -1, 0, or 1 were 19% in the ketamine group and 41.2% in the midazolam group for a p-value of 0.002. This study did display that there were more patients in the midazolam group who had a RASS goal or a RASS score of less than or equal to -2, which meant that the ketamine group did cause increased sedation compared to midazolam. Additional sedating agents within 1 hour of ED arrival. So this was 36.4 in the ketamine group and 17.6 in the midazolam group for a p-value of 0.015. I think this also goes along with the pharmacokinetics that we talked about on the earlier slides. Additional airway supporting devices, this is like bag mask ventilation, 46.2% in the ketamine group required additional airway support compared to 14.7% in the midazolam group for a p-value of less than 0.001. The author's conclusion from this study was that there was no difference amongst the groups for endotracheal intubation. However, the ketamine group did experience a RASS of less than or equal to -2 more often, and more patients required additional sedation and airway support in the emergency department. And then the last study we're going to look at is the efficacy of ketamine for initial control of acute agitation in the emergency department. This was done in 2021, a prospective single institution randomized open label pilot study. There were 86 adult patients with an active diagnosis of combative agitation enrolled by ED physicians. So ED physicians were trained to screen and randomize patients to a ketamine group or a haloperidol and lorazepam group. The primary outcome that they looked at was sedation So within 5 minutes, 22% of ketamine patients did experience sedation compared to 0 in the haloperidol and lorazepam group for a p-value of 0.001. Sedation at 15 minutes was 66% in the ketamine group and 7% in the haloperidol lorazepam group for another statistically significant p-value. And the median RASS at 30 minutes was -1 in the ketamine group and 0 in the haloperidol lorazepam group for a p-value of 0.016. The author's conclusion was that ketamine was associated with significantly shorter time to sedation compared to haloperidol and lorazepam and achieved deeper sedation. I will say I would have liked to see this study complete with the ACCP recommendations of midazolam and droperidol. I think since they are the combination that's recommended for the quickest onset, I would have liked to see that directly compared to ketamine. So now getting into my study that I dug into, the primary objective was to compare the use of emergent out-of-hospital airway support after the administration of ketamine or midazolam for out-of-hospital acute behavioral disturbance. Secondary objectives were to evaluate out-of-hospital and ED complications and outcomes for patients who received ketamine or midazolam for acute behavioral disturbance. This is a retrospective cohort study completed from February 6, 2017 to February 9, 2021, so about 4 years. They included patients of any age. They examined out-of-hospital electronic health records and included patients based on the drugs they received. So if there were medications mentioned, the name ketamine, Versed, or midazolam in the EHR, they were included in the study. And then they were narrowed down further based on free text notes that were used to determine if they were experiencing acute agitation or not, which we'll talk about in a slide in the future. They were excluded from the study if medications were administered for other indications, including endotracheal intubation, seizure, injury, dyspnea, and other that they did not specify. They utilized the EMS dosing protocol, which was midazolam 1 to 5 milligrams intramuscularly or intravenously, repeated every 2 to 5 minutes as needed. The ketamine dosing for this protocol was 5 mg per kg intramuscularly once with a max dose of 500 milligrams. I will say that in the study, they talked about how in 2016, this EMS agency made a switch from a 3 mg per kg with a max dose of 300 milligram recommendation to this 5 mg per kg. And this happened right before this study started. The EMS had a standing order for ketamine to be administered intramuscularly. Intravenous administration required a medical consultation from a physician online. The primary outcome was emergent out-of-hospital advanced airway management after medication treatment for acute behavioral disturbance. Some secondary outcomes that they looked at were use of advanced airway management in the ED, documentation of medication-associated hypoxemia, receipt of additional sedation, cardiac arrest following drug administration, disposition from the ED, admission to the ICU, duration of mechanical ventilation, length of hospital stay, and final discharge disposition. So like I said earlier, they had kind of a complicated screening process for these patients. So initially, over 250,000 patients were eligible for this study. 253,649 patients were excluded because they did not have mention of midazolam or ketamine in their EHR. From there, there were 2 independent reviewers who looked at each of these cases to determine if there were any of the screening terms that were found. If there were screening terms present, this went to a physician review panel who then examined the cases and excluded patients based on if the midazolam and ketamine were administered for other indications. If there was any discrepancy between the review board, it would go to additional physicians to review and to make the determination if the patients actually were treated for acute agitation. After all of this was done, the final patient cohort was 376 patients. The ketamine group was younger at 36 years old compared to the midazolam group, which was 42 years old. The midazolam group was 30% women, and the ketamine group was 16% women. However, I do not expect these differences to affect outcomes greatly. 50% of the patients in the midazolam group required restraints compared to 80% in the ketamine group had restraints reported. However, it's not confirmed how many of these patients actually had them placed or what the circumstances and timing of the restraints were. There were some statistically significant differences in the primary cause of the acute behavioral disturbance. There was a difference with more patients in the Midazolam group experiencing post-ictal agitation, glycemic emergency, cardiovascular complication, dyspnea, or other conditions which were not specified. In the group who was agitated due to substance abuse, there was a significant difference, with 64% of the ketamine group having some sort of underlying substance abuse, and compared to 33% with the Midazolam group. When examining the toxicology panels, there was significant difference in patients who tested positive for amphetamines, with 43% of the ketamine group testing positive compared to 19% in the Midazolam group. It doesn't surprise me that there was a difference amongst the groups in those who tested positive for benzodiazepines, with 54% of the Midazolam group testing positive compared to 18% of the ketamine group. What does surprise me is the amount of patients who tested positive for the benzos in the Midazolam group, which was 74 patients. Since Midazolam is a benzodiazepine, I would have expected close to all of these patients to have had a panel done and tested positive for benzos. However, there were about 54 patients who had a panel done who did not test positive. The ketamine group had a higher systolic and diastolic blood pressure and a pulse rate when measured by EMS. It's not known whether these vitals were taken before or after administration of the ketamine. I suspect most of these would be after ketamine administration once the patient had calmed, which would explain the differences, as ketamine can cause hypertension and tachycardia. If the vitals were taken before administration of the ketamine, I would question the agent selection by EMS, as in some cases, when patients are hypertensive or tachycardic, I may be inclined to hold on administering ketamine due to a side effect risk. When analyzing the primary outcome, there wasn't a statistically significant difference in terms of airway management. Each group was evenly split in the tracheal tube and bag mask ventilation group. I think the conclusion we can draw from this result is that most patients in the study were able to maintain their own airway. This outcome is surprising to me based on the ketamine dose administered. Prior to reading the results, I expected a much larger amount of people to have required intubation ketamine group compared to those who ended up requiring it. So out-of-hospital cardiac arrest was surprising to me, especially with the Midazolam administration after, which was when they had the arrest after sedation. I do question the arrest before sedative medication results and wonder what the indication actually was for the administration of the Midazolam. Was this for intubation after achieving ROSC and the screening physician just missed this? It's difficult to draw a conclusion from their arrest after sedative medication because it's unknown what the etiology was in the out-of-hospital setting or how close it actually was to the medication administration. There was a difference in the patients with available hospital records. So there were some patients that were transported to EDs that were not included in the study. So once they were transported to the EDs, they could no longer have their health records examined. There were 138 patients in the Midazolam first group and 207 patients in the ketamine first group who were able to have their outcomes examined because they were taken to EDs that were included in study approval. Similar to the out-of-hospital results, most patients were able to maintain their own airway once they were in the ED. Advanced airway, whether it was EMS or ED place, was similar amongst both groups. Disposition from the ED and final discharge was different amongst the groups. There was a notable difference with 114 patients being discharged from the ketamine group compared to 59 patients in the Midazolam group. There was a much higher substance abuse patient population in the ketamine group, which could explain this large difference, as there could have been some more of the sober and go situations in the ketamine group. Additionally, they did not have a group for patients going from the ED to a rehab facility, which could have been a destination for some of these substance abuse patients that were in the ketamine group, and that was not specifically called out. So who knows if this was lumped in with patients who were directly discharged from the ED. So looking at strength of this study, they did do a multivariable logistics regression that was used to account for confounding. The initial population was large. They had a lot of patients to draw from. Inter-rater variability was assessed by an independent reviewer. So like I said earlier, if there was any difference between how the physicians assessed patients for acute agitation, they did have an independent reviewer review the case to determine if the patient was actually acutely agitated. And then I do appreciate that while this was a study focused on the out-of-hospital setting, that they included both out-of-hospital and hospital record data. It was collected and compared for the reader. So there were some limitations of this study. This was retrospective and observational. I will say that the reviewers who looked at these patients to determine if they were actually acutely agitated in an out-of-hospital setting knew the hypothesis, so I think this could have led to some bias. I do think the method of screening patients was questionable. They included many terms. However, you can never be sure that it's going to be a comprehensive list. So I think that they could have missed a lot of patients just because they had a narrow list of terms that they identified patients by. Some terms I think that could have identified patients were patients who experience altered mental status, withdrawal, visual or auditory disturbances. And a lot of the terms they utilized also had negative connotation associated with them, like aggressive, naked, spitting. And while sometimes these patients can be aggressive, not all of our patients who are acutely agitated are going to be showing aggression to EMS or hospital staff. I think the dosing protocol was another limitation. The Midazolam dose was very small compared to the large ketamine dose of 5 mg per kg. I would expect an equivalent dose to ketamine group for Midazolam to be about 10 milligrams, and it was much lower than that. So I think that it could be helpful to do a comparison with lower doses or a higher Midazolam dose that is equivalent to the ketamine group. I do recognize that they were limited by the current EMS protocol that was in place. The author's conclusion was that ketamine is a reasonable option for acute behavioral disturbance treatment, achieving an airway safety profile that does not differ from Midazolam. So what do we do with this information? Like I said earlier, EMS protocol did not have equivalent dosing. I definitely would like to see a study done comparing these two that have more equivalent dosing. Ideally, based on the ACCP recommendations, I would have liked to see this study done using droperidol in addition to the Midazolam, since that is the recommended combination. Neither group demonstrated a difference in airway support or a need for additional sedation, which is great, but I don't think that you can definitively draw the conclusion that one regimen is superior to the other based on this study. That is the conclusion of my presentation. I'll be happy to take any questions that the audience has.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.